Good evening, one and all. I'm Dr. Bhuvaneshwari Rajendran. I would like to thank Dr. Karthikeyan and the Hamsa team to reach out to all. This is unprecedented time for all of us. We are in the midst of a pandemic, and there is a lot of time with us. We have to use it wisely. So we are in the process of learning more, and this is one of the steps that we are doing to do that. Today, I was asked to talk about stroke. What is stroke? What is acute stroke? And how do you manage acute stroke? Now, stroke is very much similar to heart attack. Just how you can have a blood vessel in the heart blocked, causing severe pain and also cardiac arrest even. Similarly, the blood vessels in the brain, when there is a block in the blood flow to a particular area of the brain, because of that reason, that particular area of the brain gets damaged and you get stroke. And this is the majority of the strokes, because stroke can also be caused by a bleed. And so if you look at stroke, it is not as simple as a heart attack. So heart attack is always because of a blood clot in the blood vessel. Whereas the stroke, you can have two mechanisms. Majority of the strokes that we see is because of a clot in the blood vessel. But there's a 15% chance that the stroke that you're dealing with could be because of a bleed, that is burst in the blood vessel. And stroke is a very, very common problem. Almost 15 million people worldwide suffer from stroke every year. And it is one of the biggest cause for permanent disability all around the world. So stroke is something that we need to be aware of. We need to know how to prevent strokes, how to deal with acute strokes so that the disability is reduced or almost not there. As I told you earlier, stroke is of two mechanisms. One is because of a block. So the block actually happens in the blood vessel, causing lack of flow of blood to a particular region. And then, therefore, there is brain damage. The second mechanism is, for example, if the blood pressure shoots up, which is called as accelerated hypertension, you can have a burst of the blood vessel, causing bleed, and a particular area of the brain is affected because of that. And that is called hemorrhagic stroke. 85% of the strokes that we see is because of the blood clot, and 15% is because of the bleed. This is a little cartoon that shows you the difference between an ischemic stroke or a blood clot stroke and a hemorrhagic stroke. As you can see on your left here, because there is blood flow that is cut off because of a clot here, this area of brain is damaged. And that causes symptoms based on the position of the brain damage. Here, the blood vessel has burst and there's blood that is which is flowing around and causing brain damage on the right side, and that is a hemorrhagic stroke. So how does one recognize stroke? Because stroke is an emergency, and we know that if you understand and recognize stroke early, seeking medical help early and also acute intervention is going to make a huge difference. By that acute intervention, we are either able to completely reduce the disability or restore blood flow immediately and prevent stroke from happening, or we can reduce the damage that is going to be caused because of the lack of blood flow. So it is important to recognize stroke as early as possible. When someone is looking as if he's not well, there's a facial droop, or is not able to move the upper or lower limb on one side, he's got slurring of speech, or if they have acute dizziness which is uncontrollable, they feel like vomiting, then unable to walk, then you have to think about stroke, especially if a patient is diabetic, hypertensive, got dyslipidemia, and has got complaints such as these, you definitely have to think of stroke immediately and go to the hospital where acute stroke is treated. Now, a very, very common and very useful mnemonic that we are advocating all around the world to recognize stroke is called FAST. Now, the FAST here, the F in the FAST stands for facial asymmetry or weakness. So if you have a droop on one side of the face, then please take note. If there is weakness of the upper or lower limb on one side, again, the alarm bell should go off. If the patient is having speaking difficulties, is unable to speak, or there is slurring of speech, please take a note. And of course, as I said, time is very, very important. If you recognize stroke, immediately take the patient to the hospital. Within 4.5 hours, if you reach this hospital from the onset of stroke, we can do acute intervention and help reduce the disability. So when you go to the hospital, what happens? As soon as the patient is brought into the emergency, the patient is fully examined, but very, very quickly, we have some scales, stroke scales called the NIHS scaling, which is very useful to understand objectively how much is weakness. And then we take the patient for a CT. An MRI is also done, but if you really are pushed for time, a CT is the best tool. Make sure that the stroke is not because of a bleed, because this is where stroke is different from a heart attack. As I said earlier, heart attack is always because of a blood clot. So even if someone complains of chest pain at home, we say, please give that patient some aspirin or blood thinners at home itself. But for stroke, we don't do that. We ask the patient to come to the hospital because we want to make sure it is an ischemic stroke or a stroke because of a blood clot and not because of bleed. Because the management of a hemorrhagic stroke is completely different to the management of a stroke because of the blood clot. So this tool, the CT, is going to be a very useful tool in making that differentiation. So once we establish that the stroke is because of the blood clot, we quickly do all of the other blood tests, blood pressure, ECG, and so on. And once this is how your CT is going to be looking. So if there is a ischemic stroke, on the CT, you'll see a darker shadow like this. Whereas if it is a hemorrhagic stroke, you're going to see a lighter shadow or a whitish mark. So this darker shadow is called hypodensity, and that indicates that there is an ischemic stroke. Once that is established, we immediately have to intervene. So I told you earlier, the stroke, ischemic stroke, is because of a blood clot, which is blocking the blood flow and causing brain damage. So we have to, what do? We immediately give them a blood thinner medication, a very strong blood thinner medication as an injection. And we have to give that within 4.5 hours from the onset of stroke. And when we are able to do that, we can help reduce the disability that is caused by the stroke. There are several studies that have come out to prove this, and if you take the patient to a center where this is done on a routine basis, then the results are going to be wonderful. The result may not be immediate. Immediately, in all patients, we don't see a dramatic recovery, but when we assess the patient over 3 months from the onset of stroke, patient who has received thrombolysis or the blood thinner medication does so much better than a patient who has not received the blood thinner medication. So time is valuable. 4.5 hours is the golden period post-stroke. You have to get the patient into the hospital when you've recognized stroke as early as possible. Of course, when you have a hemorrhagic stroke, as seen on the CT, then the management is totally different. As I told you, most of the times, a hemorrhagic stroke is associated with very high blood pressure. So our immediate intervention would be to reduce the blood pressure so that the bleeding is reduced. And when there is bleeding in the brain, like what happens in other tissues, around the bleeding, we also see swelling or edema. So we have to put them on medications to reduce this swelling or edema. And we also sometimes depending on the location of the bleed, have to treat them with anti-epileptic medication as prophylaxis, preventive medication, so that these patients do not get seizures. And apart from doing the acute intervention, we also have to find out if there is a blood clot. Where is the blood clot coming from? Is the blood clot in the brain blood vessels itself, or is it coming from a distant location? And the commonest positions from where the blood clot can travel into the brain is, one is the heart and one is the the neck vessels, the carotid blood vessels or the vertebral blood vessels in the neck, depending on whether you have an anterior stroke or posterior stroke. So as we are treating the patient in the stroke ward, we get ECG, echocardiogram, and Doppler neck vessels to assess the blood flow to make sure there's no major stenosis of these blood vessels from where small pieces of blood clots can travel into the brain and cause stroke. And if a patient has had hemorrhagic stroke, we also check if the patient has got any bleeding issues or on medication which can cause bleeding. So these are the different interventions that we do apart from giving the thrombolysis. As I told you earlier, the two important areas from where a blood clot can travel into the brain, one is the heart and one is the blood vessel in the neck. Now, as you can see in this cartoon, the heart, when I say heart, what happens is there is a rhythm in the heart called the sinus rhythm. This is the normal rhythm for every patient. Whereas when the patient has got an irregular heart rate, which is called atrial fibrillation, instead of the heart going labda, the heart will go very irregularly. When that happens, then the blood flows through the heart. Because of the irregularity in the way the heart contracts, there can be clot formation in the heart. And that clot can travel into the brain and cause strokes. So this atrial fibrillation or the irregular heart rhythm puts the risk for having a stroke up by another 20%. So any patient who we see is having atrial fibrillation, we put them on strong anticoagulant or blood thinners to prevent strokes in these patients, as their risk for stroke goes up by 20% by the mere presence of atrial fibrillation. The second intervention, of course, as I said, it is this carotids. So we look at the carotids to see if there is any plaque formation or stenosis in the blood vessels from where blood clots can travel. So in that case, we actually advise the patient to undergo either stenting to make sure that the blood flows better, or endarterectomy, which means there is like a bypass surgery for the blood vessel in the neck. And this has to be done within 2 weeks from the onset of stroke for better results and to prevent further strokes. Once the stroke has happened, apart from the acute interventions, we should also think about how do we protect this patient from having further strokes. Now for this, we follow the mnemonic A, B, C, D, E. What is A? A, we give them blood thinners, antiplatelets. B, we control their blood pressure. And C, if they have any vices like smoking or alcohol, we ask them to stop it immediately. So cessation of cigarette smoking or cholesterol lowering medication stands for C. And then diabetic control, exercise. So these are the measures that we advise for a patient to protect the patient from further strokes. And of course, as I told you, we talked about what do we do if the patient has got irregular heart rate, and also what do we do if there is stenosis of the blood vessel in the neck. And as you know, stroke is one of the biggest causes for disability because it causes permanent damage to the brain cells. Now, as a result of this permanent damage to the brain cells, patient could have paralysis, could have speech problems, memory issues, visual problems, even death if the stroke is very, very severe. So that is why stroke treatment is so vital, not just to prevent mortality, but also to prevent morbidity or long-term disability. As I told you earlier, the two main interventions that are being used worldwide in acute stroke centers. One is the anticoagulation, the thrombolysis, that is the injection of strong blood thinner, which is done within 4.5 hours from the onset of stroke. And the second intervention that has made a huge change to the management of stroke is the mechanical recanalization or mechanical thrombectomy. Just like what happens in the heart, when there is a blood clot, patient undergoes what is called a stenting. So they remove the clot, angioplasty, and they do a stenting so that the blood flow is restored in the blood vessel. Similarly, we can do this in the brain, especially if we are dealing with large blood vessel and clots inside the large blood vessels, which is easily amenable to this angiographic method of removal of the clot. So, as I said, these two interventions have made a huge change in the shift or in the management of stroke across the world. So, for both these procedures to be successful, time is important. Time is brain. So, unless you have recognized that the patient has got stroke and brought them into hospital early, none of these interventions are possible. And so, we are not able to help the patient really. But if you recognize the patient having stroke early, and if you bring the patient early into the hospital, it makes a huge difference. The two important procedures or intervention, one is the thrombolysis, the second one is the mechanical thrombectomy. As you can see in the cartoon, they're using this device to remove the clot and to reduce the damage in the brain. Let me stress again, recognition of stroke is the most vital step in the management of stroke. Use the mnemonic FAST. F stands for facial asymmetry, A stands for arm or leg weakness, S stands for speech impediment, and T is time. Now, what happens when the patient has got hemorrhagic stroke? Hemorrhagic stroke, as I said, is usually associated with high blood pressure. So our immediate intervention would be to reduce the blood pressure so that further bleeding from the blood vessel is not there. So as soon as the patient comes in, once the CT is done and we show that there is a bleed, we actually put them on blood pressure lowering drugs and lower the blood pressure. We want to aim a target blood pressure of 140/80 in the ICU so that further bleed is prevented. And as I told you earlier, when there is a bleed in the brain, there will be some amount of edema around the area of bleed. And that could cause more damage to the brain because of the pressure effect. So we have to reduce the brain edema by using medications and also certain interventions like hyperventilation and so on. So when we do that, and also these patients are very much prone to seizures because when there is a bleed in the brain, they cause irritation to the brain cells and cause seizures. So we also put them on antiepileptic medication so that they do not get seizures, which can make life more difficult. Now, we have looked at what happens to a patient when they have acute stroke, whether it's an ischemic stroke or a hemorrhagic stroke. A stroke ward is the place where the patient is admitted, and in the stroke ward, the specialized stroke ward, the nurses and the doctors who are manning the stroke ward know exactly how to look after this patient, because once we do the acute intervention, be it thrombolysis or mechanical thrombectomy, the observation of the patient is very, very important, because these patients, the first 24 hours to 48 hours is very, very crucial. These patients can have restrokes, can have seizures, can have aspiration because swallowing is affected because of the stroke. They can get, high blood pressure causing bleed. Sometimes when we do thrombolysis, there is a 5% chance of bleed. So you do not want increased chance of, bleed as a side effect of thrombolysis. So these are problems that we anticipate, and what it is called intense neuro observation. And this is what is done in the stroke ward for the first 24 to 48 hours. Once the patient is stabilized and we know that there has been no further complications from the stroke in the 24 to 48 hours, then we start thinking about rehabilitation, taking the patient to the ward. What do we do next? The other important thing that we always do is any intervention is done on that particular day of arrival to the stroke, we always do a follow-up CT or an MRI brain the next day in 24 hours time. We want to see how our intervention has helped the patient. So we always do a 24-hour period CT scan or an MRI scan to make sure that our intervention has helped, has made a difference to the patient. And after the intense observation for 48 hours and after making sure that the patient has had no further complication, we start planning shift of the patient to the ward from where we can start rehabilitation. Now, another phenomena when we talk about stroke that we should definitely discuss is TIA. Now, TIA means transient ischemic attack. Now, transient ischemic attack is like a warning stroke. What happens is a patient would say to you that he had either weakness like stroke, a mild weakness of the upper or lower limb. He could have speech difficulty. He could have severe dizziness. He would have, visual problems. But what happens is, unlike stroke, it is not permanent. So they immediately get better. The getting better can be within 10 minutes. It can be in few hours. Within 24 hours, if the patient is getting better on his own spontaneously, then this is called transient ischemic attack. Now, why is this important? As I said, this is like a warning stroke or a mini stroke. We have to heed to this warning and make sure that this patient is investigated further to find out what his risks are for having a major stroke. If you do not take TIA seriously, these patients who have had TIAs, they can go on to have a major stroke. Almost 60% of these patients who have had TIAs can have strokes later. So it's very, very important that if someone has had TIA, they come and meet the neurologist. Once you tell them what has happened, the neurologist will take you through a few tests that will include, as I told you, like what we do for stroke, we do the ECG. We want to know what the rhythm of the heart is, make sure there's no irregularity in the heart rhythm. We want to look at the echo, so how the heart is functioning. There is no clot in the heart's contraction are good. We also do Doppler neck vessels. We look at the blood vessels in the neck to make sure there's no clot there or stenosis there, which increases your stroke risk. We look at your diabetic status, your hypertensive status. We make sure your thyroid is controlled well. And then we put you on blood thinners, appropriate blood thinners, and make sure that you do not develop strokes as once the TIAs happen. So it's very important to recognize TIA. Now, when we talk about prevention of stroke, it is a lifestyle-related condition. Of course, genetics play a very, very important role, but in addition to the genetic predisposition, our lifestyle is very, very important. The blood pressure, diabetes, our diet, dyslipidemia, vices like smoking, alcohol, obstructive sleep apnea. This is a not very common problem as a risk factor, but more and more research is coming to show that obstructive sleep apnea, where patients have severe snoring and apneas during the night, is an independent risk factors for strokes and heart diseases, and it can put the blood pressure very, very high. So it is very important that when we have these conditions, we keep things under control. And we need to control our diet. We need to make sure that we are exercising well. And if we have suffering from other mental issues like depression, then we need to seek medical help and keep ourselves healthy for prevention of stroke. So lifestyle is very, very important. Diet, exercises, making sure that we do not have vices, and keeping a tab on our health, making sure that we undergo regular checks, especially after the age of 40. If there's a strong family history of diabetes, hypertension, cardiac conditions, it is important that you go through tests on a regular basis, at least once a year. Keep in touch with a family doctor. Make sure that you are on track, on ahead of what is happening in life. So, stroke is a treatable condition. Recognition of stroke is very, very important. So, you at home play a very big role in the management of stroke. If you recognize stroke, bring the patient to the hospital immediately, especially to a hospital where we have the setup, the facilities for acute intervention, such as the IV thrombolysis or mechanical thrombectomy, depending on the patient's requirement, so that the disability that happens with the stroke is reduced or almost nil. So, as I told you earlier, stroke is treatable. Act fast, recognize stroke, and come to the hospital in time. This is my presentation on stroke. Dr. Karthikeyan?
Madam, here?
Yes.
Yes.
I completed my presentation on stroke.
Very good.
If you have any questions, they can ask.
Yes, madam. Yes, madam. So, thank you, Dr. Bhuvaneshwari, for a very precise, at the same time conveying all the relevant information which is needed for the stroke management. And the presentation was very nice. We have a few questions from our attendees.
Okay.
Which I would like to just a minute. So, yes. So, we have a question that what can do at home.
Is that the answers? I'm seeing it, I think.
Oh, is it? Oh, if you are able to.
I'll answer that? Yeah.
Yes, please, madam, please.
Okay. So the first question was, what can one do at home before taking to hospital? See, as I told earlier, for a heart attack, heart attack is always because of a blood clot. So many of the doctors, family physicians, and even the cardiologists will tell you, give aspirin to the patient before coming to the hospital, or give medications to reduce the chest pain, right? But in stroke, the problem is stroke is not a painful condition. So there's no pain involved. However, because stroke can be caused both by blood clot and as well as a bleed, it is very important that we do not give aspirin before establishing whether it is a clot or a bleed. So you have to bring the patient to the hospital where we do imaging, especially CT, to rule out that there is no bleed, and then we give the blood thinners. Because what happens is, if you give a blood thinner at home without knowing whether it's a hemorrhagic stroke, you can actually make the stroke worse by giving a blood thinner. So there is no intervention as such at home, but what you can do is, the blood pressure is very high. Say, for example, blood pressure in that patient, you have a blood pressure monitoring machine and it's showing 200. You can give his regular medication, one start tablet before you come into the hospital. That would help. But not any blood thinners, no aspirin or clopidogrel in the house before you get to the hospital. It's important you recognize stroke, bring the patient to the hospital. Okay. And the second question is, why 4.5 hours? Okay. Now, again, there's been a lot of studies, as I told you, about these interventions, acute stroke interventions. These studies have looked at what would be the ideal time period during which the intervention is going to make a huge difference. Now, they looked at 3 hours, they looked at 3.5 hours, they looked at 4 hours and 4.5 hours. And beyond 4.5, 5 and 6 hours, interventions were not making a huge change in the patient's outcome. Whereas if the intervention are happening within 4.5 hours. Ideally speaking, in fact, many of the acute stroke centers across the world insist that you come within 3.5 hours. But because in countries like India, getting to a stroke hospital is so difficult with the traffic and all that, sometimes the 4.5 hours itself is not met because of various circumstances. So I think 4.5 hours is a good time period for any intervention. Ideally speaking, 3.5 hours would be best. In fact, even to be very precise as to when you have maximum benefit is, they say, first 90 minutes from the onset of stroke, which very, very few people are able to achieve. If you're staying very close to the hospital, then perhaps yes. But if you're staying very far from the hospital, that is like a utopian, ask. So always having 90 minutes is not feasible or practical. So 4.5 hours is a good time for intervention. Okay. When to begin rehab? Always, as we need to think rehab as soon as the patient is clinically stable from the acute stroke, because the early rehabilitation is also going to make a huge difference to the patient's outcome. So as I said earlier, in the stroke ward, 24 to 48 hours, make sure there are no complications from the acute stroke. We shift the patient to the ward. Once the patient is shifted to the ward, we start assessing the patient. Where is the patient? How much of disability does the patient have? Is he able to swallow? Is he able to talk well? How much of weakness does he have? So how much of physiotherapy this patient requires? How much of speech therapy this patient requires? What are the swallowing assessments we do? So all this will start as soon as the patient is clinically stable, which will happen mostly in most patients after 48 hours, maximum 72 hours. 48 hours is what we normally do, unless the patient has got other complications or a very big stroke where the patient is severely affected and has to stay in ICU for longer period. Cerebral aneurysm. Cerebral aneurysm causes bleed always. Cerebral aneurysm is basically a defect in the blood vessel, where the blood vessel is normally like a tube. Whereas when you have aneurysm, there's a defect in the wall of the blood vessel and there's some ballooning. So because of the ballooning, the vessel wall is very thin and fragile. So it can break and cause bleed. So cerebral aneurysm always causes a bleed, especially a bleed called subarachnoid bleed, which is like a not very deep bleed, more on the surfaces or the arachnoid or the meningeal surfaces. So that is a different type of stroke. It's not a typical stroke, but for that, again, the intervention is very, very different. We have to go and make sure that this aneurysm doesn't keep on bleeding. So you have to clip or coil the aneurysm. So that's a different topic on its own. But let me tell you, aneurysm always causes bleed and it's more a subarachnoid hemorrhage. I think we answered a rehab question. 1 minute. And then there is no movement on the slide. Okay.
Any fatality differences in ischemic and hemorrhagic stroke?
Hemorrhagic stroke. Yes, hemorrhagic stroke. See, it all depends on the size of the stroke, whether it's hemorrhage or ischemic stroke. It depends on how big, what is the area of brain that is affected. Now, if you have a major stroke with a large blood vessel that is blocked, see, think of blood vessels like tree branches, okay? So you have a large branch which then divides into smaller branches as you go towards the tips, right? Now, if you have a small clot blocking the smaller branches, then the area of brain damage is smaller. So the effect of stroke, the effect of brain damage is also less. The stroke is not going to be very severe. Whereas if the large branch is blocked, then you can imagine the whole of that area is going to be damaged. So the area of brain involved is going to be huge. So when the area of brain is large, we have a greater mortality and morbidity because of the area involved. Especially when we look at the blood vessels in our brain, there are three main blood vessels that supply the brain. One is the anterior circulation, consisting of the middle cerebral artery and the anterior cerebral artery. And in the posterior brain, we have the posterior cerebral artery. Now, the middle cerebral artery is the most important artery to the brain. Now, when you have a clot, that is the large branch, middle cerebral artery. When you have a clot in middle cerebral artery, that means the stroke or the brain damage is going to be large. So even bleed, it is the same. If you have a large bleed involving a large area of brain, then the outcome or the fatality is going to be much more. Young stroke, causes of young stroke. Okay. This again is very important because we are seeing a lot of young patients coming with strokes. And here we not only look at risk factors like diabetes, hypertension, and lipids, but we also want to look at whether there is a strong genetic predisposition, any cardiac problems, because one of the major sources of blood clots in younger people could be a hidden cardiac problem. So we look at various cardiac problems. We look at how they clot, because normally if you think about how the blood flows in the blood vessel, it's flowing very freely like water, right? But if you have a clotting problem, then your blood gets thicker and is very much prone to clots, and that's going to cause problems. There are certain people who have problems with coagulation. It is a genetic problem. And in these patients, they are highly at risk for having further stroke. So we want to make sure when young patients are coming with stroke, we look at the heart thoroughly to make sure there's no cardiac origin. We look at their clotting profile to be sure that they do not have any clotting issues. In that case, we have to put them on stronger blood thinners. So younger patients, the stroke, we look at various other factors other than the lifestyle diseases like diabetes and hypertension. Okay. Will there be speech disturbances during TIA? Yes, definitely. Like stroke, it's a mini stroke. So you can have speech disturbances and weakness of limbs during a TIA. But as I said, it's not a permanent damage. It will be a transient effect. And that's why it's called a warning stroke. Okay, multiple cavernomas. Now, cavernoma is a cause for bleed. As you have actually said, it can have bleed. And the most common ways how a patient presents to us would be either a bleed, or because of small bleeds in the cavernoma, patient gets a lot of headaches, and patient can have seizures because of the irritation because of the cavernoma itself or the bleed that is caused by the cavernoma. So again, it is a surgical management of the cavernoma and location and so on. It is not exactly the common cause for stroke, but so we do not include a cavernoma bleed in the stroke acute stroke. It is dealt as a separate problem. Spontaneous recovery versus acute rehab. I mean, spontaneous recovery, as I said, for 24 to 48 hours, once the patient is stable, we have to assess the patient. We need to know at what level the Rankin score, his disability score is very important. We need to know what are his problems post-stroke. And then our rehab is planned according to the disability. I'm sure Dr. Karthikeyan would agree on that. Am I right, doctor?
Yes. Yes, madam. Yes, you are right.
So, and then when should rehabilitation start? ASAP. As soon as the patient is clinically stable from the acute stroke, you think about rehabilitation. Start planning. Every patient is different, and the rehab for that particular patient is tailor-made for that particular patient. Generalized, you say physiotherapy, you say speech therapy, you say swallow therapy, yes. But how much of intervention is required for each patient differs, and you have to base it on the patient's level of disability. How common are recurrent strokes? I mean, there is no 100% foolproof method to prevent strokes. When you have risk factors and when you are on the right medication, for prevention of stroke, there's a 90 to 95% chance that you are helping yourself. 5 to 10%, you can, there's only so much you can do. But definitely that 90 to 95% protection makes a difference. How is dysphagia related to stroke? Now, when the stroke happens, when the brain is damaged, it's not only motor weakness, not only speech. There are so many areas that is affected. So we don't talk about the cognitive problems that can happen after stroke. So when there is a big area of brain damage, it is not only the motor problems that you see. The patient's personality is affected. He could have memory issues. He could have judgmental issues. So there are lots of issues that we think about. And when the swallowing muscles are affected, they have difficulty swallowing. So there is high risk of aspiration. So the dysphagia is a manifestation of your stroke. What are anti-epileptic? What are anti-epileptic? I mean, as I said, we don't have to use anti-epileptics for every stroke. Especially ischemic strokes, we don't use anti-epileptics on a regular basis. We only use an anti-epileptic in ischemic strokes if the patient has had seizures. Otherwise, we don't use anti-epileptics as a regular medication. But for a hemorrhagic stroke, especially with a large bleed, we do think about using prophylactic anti-epileptics, which could be a levetiracetam or a phenytoin, depending on the patient, because only a large bleed can cause the increased chances of having a seizures happen with a bleed, not so much with the ischemic stroke. What will be the precautions taken at home having a hemorrhagic? As I said, blood pressure could be high. You can actually give them a medication to lower the blood pressure when you bring them as you're coming to the hospital. To which stroke recovery is good? It all depends on the size of the brain involved, brain damage, whether it's a hemorrhagic stroke or ischemic stroke. If you have a smaller area of brain involved, then your recovery is going to be better. If it's a large area involvement, of course, your recovery is going to be delayed. In terms of symptoms, no. That's why it's very, very important that we have to do the CT, because both ischemic and hemorrhagic stroke will have similar manifestations, which is the weakness and slurring and so on. So you may not be able to make out the difference at home without the CT. Even as doctors, when we look at the patients, it's hard. Okay, we get clues by looking at the blood pressure and other factors, but we cannot say for sure that this is hemorrhagic or ischemic just looking at the patient. What is the right way to ambulate the patient? What do you mean, to the hospital or post stroke? I'm not very sure about that question, but ideally an ambulance would be better. If you're thinking about acute stroke and getting the patient to hospital, call an ambulance, either the hospital ambulance or 108. Use the right ambulance for the right location where you are. Does stroke affect respiratory muscles? Yes, it can affect respiratory muscles because, as I said, brainstem strokes, the posterior strokes, where the main problem may not be the motor weakness. Brainstem strokes are very unique, where the patient can lose consciousness, will have breathing difficulties, will have blood pressure fluctuations, will have irregularities in the heart rhythms post-stroke. So the dizziness, vomiting. So brainstem stroke can be very different in the presentation compared to an anterior stroke. Anterior stroke happens in the front, posterior stroke happens in the back, and in posterior stroke, the brainstem strokes are dangerous strokes because it can affect breathing. If someone already is taking blood thinners, yes, even if they are on aspirin, we do thrombolize the patient. We do INR, we have these quick ways of finding out the INR. Even if they are on warfarin like blood thinners, we do INR, and we actually look at the INR value, which is 1.7. If the INR is less than 1.7, we actually take the risk and go and thrombolize the patient. If it is more than 1.7 or 1.7, then we have to take a call as to whether we are going to cause bleeding by thrombolizing, because they are strong blood thinners. So Aspirin and clopidogrel, no problem, we will thrombolyze the patient. What is the duration? As I said, duration of TIA is 24 hours maximum, but it can range between 10 minutes to a few hours. The speech difficulty as other facial weakness also indicates. Yes. Yes, that's why we said fast. Fast includes facial asymmetry and speech problems. I cannot say it is fatal in middle-aged person, but young people having strokes, we are a little bit concerned because it's not a simple stroke. We have to look at so many other factors, as I told you earlier. So young people having stroke, we are always more concerned. How to differentiate at home? No, you can't. Where is it? How do I know? Okay. What can we do for speech problem? We have to do speech therapy. So speech problem can be, the different aphasias you have. You have the Broca's aphasia, or you have the expressive aphasia. So depending on what kind of aphasia, or it can be a global aphasia. So both comprehension and word production is affected. So depending on what kind of aphasia the person is, we think about what kind of therapy this patient needs to have. So a role for a speech and language therapist, physiotherapist, and occupational therapist starts early, very early, as soon as the patient gets clinically stable from the acute stroke. First aid, we talked about that. Can ischemic stroke further change to hemorrhagic stroke? Now here, yes, it could, especially in older patients, and there is always a risk when we're doing thrombolysis. There's a 5 to 7% risk that there could be a bleed when we give them strong blood thinners, but we do take the risk. It's like going to a surgery. When you're undergoing a surgery, there is risk of getting infection or bleeding, but we have to take that risk and we have to intervene. So 5 to 7% risk is a very small risk. We do go for it. Even spontaneously, a large ischemic stroke can have hemorrhagic transmission, especially in older patients. So that is a complication we should keep in mind. Occupational therapy, yes, of course. The whole idea of stroke rehabilitation is getting the patient back to his normal life. So occupational therapy becomes very, very important. All the therapies, it's comes under the umbrella of rehabilitation. Speech therapy, physiotherapy, and occupational therapy. So we have, and also important is the psychological management. As I told you, there will be cognitive issues, mild depression. So you have to manage, or it could be behavioral, aggressive behavior. So all this has to be managed. It's not just the motor weakness and speech and swallowing difficulties post-stroke. Okay, what are the physiotherapy management? I think I'm not the right person to talk in detail about that. I think Dr. Karthikeyan will do that.
Yes.
What is the outcome of locked-in syndrome? That is because of a pons involvement. It's a brainstem stroke where basically the patient is only able to move the eyes. The rest of the body is not moving. So the patient is it's a ventral or the anterior pons when it's affected, you get that. So the patient becomes rigid, unable to move the entire body except for the eyes. Can heavy workouts bring about? Yes, there is this chance of a dissection of your carotid artery or vertebral artery when you do extreme exercising and stretching and so on, which can cause strokes. So that is something that we need to keep in mind. I think too much of anything is not something that we like. A moderate level, when you keep everything, it becomes easier. Wait a minute, I'm going up. Contraindications for physical therapy for strokes. The initial period, of course, for 24 to 48 hours, when the patient is not clinically stable, you don't do physical therapy at that point of time. Maybe just passive physiotherapy. But once the patient is clinically stable, we should do physiotherapy. Of course, sometimes the patient could have severe heart conditions. cardiomyopathy, dilated cardiomyopathy, or so on, where you cannot exert the patient too much. And those could be some contraindications that we keep in mind, or a COPD patient, where he gets very breathless on exertion. So, as I said, rehabilitation is not one hat that fits all. It is tailor-made for each and every patient according to their comorbidities, their level of disability. What are the medications stroke patients take? I mean, they are on blood thinners, they are on statins, they are on, if they have BP and diabetes, they'll be on those medications as well. That's called secondary prevention. Any can persist, you can have residual weakness. Chances of stroke or brain damage in patient who has done heart valve. Yes, you can. If they're not taking blood thinners regularly, they can be prone, especially the mechanical valves. Does the damage TIA cause recovery? See, basically TIA is like a small clot that goes into the blood vessel and gets flushed off. So there's no brain damage, permanent brain damage, but you have to heed to it. You have to make sure that you are doing the right things to prevent stroke. I think I've come to the last question. Yes.
Yes, thank you very much, Dr. Bhuvaneshwari. Initially, our discussion was you will be completing by 20 minutes, but it was a continuous, non-stop blast for the past 1 hour. It was excellent. It was very nice. I think all the attendees, even you got much engaged, involved in all explaining all the questions, that it has exceeded time limit what you have fixed for yourself. It was I would say it is excellent. Almost covered all the aspects of stroke, starting from the etiology, the presentation, symptomatology, and then clinical presentation, then transient ischemic attack, management, and then the role of rehabilitation. I think my job is almost completed. So, of course, I have only 5 more minutes. So that, thank you very much. It was a very excellent presentation. And for completion, just I want to contribute certain things. Though Dr. Bhuvaneshwari has very elaborately discussed about all aspects of stroke, I would say that what is the role? There were questions that what is the role of occupational therapists, physiotherapists in the management of stroke. So I think after going through all the basic aspects of stroke, various types of stroke like ischemic stroke and hemorrhagic stroke. So once the patient is in the intensive care or in the ward after having a diagnosis of stroke and having gone through the initial acute management, first we need a complete evaluation of the patient and see to that the vitals are stable. That is more important for anything. The positioning, starting, I would say, any physio or OT who are there in the intensive care, see to that the positioning is very important for various reasons. Like the head has to be positioned in the right way, and the head end has to be tilted upwards to prevent aspiration. If possible, see to that the patient is on a nasogastric tube and whether it is patent. And then the bladder, usually during the initial phase after the stroke, the bladder would be hypotonic and the patient is prone to have overflow incontinence. So all these things we have to know and get oriented with the patient's problems, and the exact rehab plan. The exact rehab plan should have 2 ideologies, which is very important. That is to prevent complications, and second is to improve the potential of the patient. So what are all the complications you anticipate in a patient with stroke, starting from motor problems like mainly the spasticity, and then the speech problems, cognitive dysfunction, respiratory, cardiovascular, and then in cardiovascular you have more chances of DVT. So all these things you should anticipate all this and see to that the patient does not get into any of these complications, because if many times the process of rehabilitation faces a major setback when the patient falls into any of these complications, because our major efforts would be focusing on that. So I would request that, see, you should have a complete orientation of what are all the possible complications a person who had a history of stroke, or who is after the acute management of the stroke. You should know all the complications. And I would say that during the initial phase of stroke, the patient will be in the state of flaccidity, right? So you should have a watchful eyes and a careful observation that as the spasticity slowly sets in, it is just like molding the clay in a potter's wheel, that you have to position the limbs properly, such a way that you are encouraging the normal voluntary movements. See to that there is no spasticity leading to contractures and deformities, and you should have a better orientation about the synergy patterns. I hope all physios and OTs know about flexor and extensor synergy patterns. So you should have a better observation what the synergy pattern the patient is developing, and accordingly you can adopt the exercise protocol. As you all know, there are Bobath protocol, and then you have Brainstorms, you have PNF techniques. So whatever which is feasible or ideal for the person, you should go for it. See to that the spasticity, as the evolution of spasticity is taken advantages and for the voluntary movements. And you should know what are all the stages of Brainstorm's motor recovery. So these are all the basic ideas you should know and carefully observe. See to that the patient slowly develops the voluntary movements. And I would say that get out of the bed as early as possible, provided the patient's vitals are stable, to avoid a lot of complications, including the deconditioning of the patient. Many times, for many reasons, especially the apprehension of the family members, the patient will be on the bed for a very long time. But after some time, after that, when we want to take the patient out, you'll have a lot of problems because of this deconditioning. So I would say that, so as early as possible, get the patient out. So these are all the things I want to add. And moreover, the role of OT, yes, they have a major role, especially the patient when they are in the poor GCS, what we call it as the coma stimulation therapy. So various modalities by which visual, auditory, proprioceptive, gustatory, olfactory. So all these are all the modalities of sensation where the patient's brain has to get introduced even there in the state of coma, so that it will encourage the brain to go for a neuroplasticity. The immediate recovery is basically due to the reperfusion along the penumbra of the brain, and the later recovery mainly depends upon the neuroplasticity, where all the interventions in OT and PT really encourages the neuroplasticity, which I want to always emphasize. Then one other question is, spasticity and flaccidity managed clinically through injections, tablets, or through soft, rough cloth rubbing? Basically, I would say that when a patient with flaccidity or spasticity, which is easy for rehab, it is always better to have a grade 1 or grade 2 spasticity, grade 1 or 2 modified Ashworth scale has spasticity than the flaccidity. It is better to have a little spastic limb than the flaccid limb. And when this spasticity is more, that is 3 or 4, whereas it is totally tight without allowing the voluntary movements, leading to contractions and deformities, then we have to intervene. But always see to that there is a difference between spasticity and the contracture. The spasticity is at the level of the muscle alone, where we can intervene, treat with medicines or injections, oral medications or injections, or intrathecal injections. But once the spasticity, a long-term spasticity, is left as such, and it has gone for anatomical shortening, that is the contracture, or associated with the joint capsule tightness, then it will lead to deformity, where surgical intervention is the only option. So that is why I always insist my physio team that always manage spasticity in the right time by right means, that is splinting, stretching, and I always advise the oral medications. If not, we can go for botulinum toxin injections or intrathecal baclofen pumps. So these are all the various interventions that are available. For flaccidity as such, we need not intervene actively as such. The only thing is we need the flaccid limb needs an external support where we can achieve it through an external orthosis. So that is what I would like to highlight. What about applying icing to reduce spasticity? Is it helpful or should not be used? Actually, there is no definite clinical evidence as such. The icing or stroking will have any impact over the spasticity. There is no definite RCTs available, but applying icing does not cause any harm for the muscle. But I don't have, in my personal experience, I don't find any advantage of icing in reducing the spasticity. That is what I feel. What are the contraindications of using oromotor occupational therapy for dysphagia patients after stroke? Contraindications as such is we should have adequate coordination and the strength of the oromotor muscles, which is very, very important. And then in the occupational therapy, what we teach, actually the oromotor occupational therapy and the speech therapy, speech and language pathologists, they closely work in this area in the management of dysphagia. For that, the prerequisite is the patient should not develop aspiration. That is more important. So make sure that the oromotor muscle strength and coordination is adequate enough to go or progress further in the rehabilitation. So that is the first and foremost prerequisite to avoid aspiration, which is a grievous complication where no patient would like to have it. I think we have covered almost all the questions. So this is what the concept of rehabilitation in stroke is. We have to know what is the etiology of the stroke, complete clinical evaluation, rehab planning with the active intervention of physiotherapists, occupational therapists, speech pathologists, then psychologists. So these are all the areas where a complete team should work together, and starting from acute management to social integration. So this is what we should have a clear plan.
Can I
think yes, madam.
Dr. Karthikeyan, many patients want to know whether starting rehab, continuing rehab at home or at a rehab center is better. They always want to know which is better, doing rehab in a center or at home. Now, how would you take it forward? How would you give the options to the patients?
Yes, madam. So whether it is a home or the rehab center, what we need is the commitment of the patient and the family members. That is more important. Many times the concept of rehabilitation faces a major setback when there is a difference between the expectation of the patient and the family members and the reality. So, for example, in a case of a cervical spine injury, we would be focusing on making the patient to sit on the chair or a bed, but they will be expecting the patient to walk. So this is what. So we should educate the family members and the patient, him or herself, see to that what is the disease as such and what is the outcome and how important the commitment of them is much needed for the rehabilitation. So if that is the case, then I would say that initially, so for practical reasons, I would say that these sort of standalone rehab centers, they can be the transition areas where they can immediately, when a person with a stroke or a spinal cord injury, if they go home, they face a lot of difficulties starting from how to position them, and even they cough for a few times, then they get panic. So they can have these rehab centers as a transition areas. They can be here for 4 to 6 weeks. They can learn what the do's and don'ts, what are all the exercises and everything. So if the patient and the patient's family members are confident enough that they can manage or take along this protocol at home, then they can very well carry forward at their home itself. Now we have even in Hamsa we have a telemedicine facility where we can have a proper follow up through video consultations. So that is what I would say. Initial for their sense of ease and comfort, they can come to rehab centers, stay here for 2 to 3 weeks, max 4 weeks, learn everything, and they can go back to their home and take it forward. And if they have any doubts, they can come. So this is what I would suggest out of my personal experience.
I have one more question. Now,
Yes.
patients, as you said earlier, patient expectations and the targets. So, is that a major, the first, what do you say, the obstacle to cross when you're actually starting rehabilitation? Is patient education and the family education to set targets?
Yes, madam. Yes, madam. I had a lot of incidents where I had a very tough time. In fact, many people showed their hard face that their expectations are so much. When a young person with spinal cord injury of 25, 26 years, they want their son to ride the bike immediately after the injury, after sustaining a thoracic level or the cervical spinal cord injury. So I would always emphasize that I'll take time. I will not compromise on that. After a complete evaluation of the patient, I will have a separate session for the patient as well as the family members. Sit with them. I will explain starting from etiology, what is the presentation, what are all the probable complications, what would be their role to prevent all these complications. Because we are with the patient for some time, that the family members are going to be with them. If they don't position the person properly, then if the person develops a bed sore, then it will lead to a bad scene. So first, patients and patients' family members' cooperation is the foremost thing that is much important for the complete and successful rehabilitation. So that is more important.
Thank you. Thanks.
Thank you very much, madam. I think we have come to the end of this session. I should again profusely thank Dr. Bhuvaneshwari for sharing her expertise and experience regarding the management of stroke. It is my pleasure to be with her during this scientific academic session and share my own views for the benefit of attendees. And last but not the least, my sincere thanks to all the attendees who patiently listened the whole of the session and expressed their questions, got it clarified. Of course, asking questions, it is very important because through their questions, many people got their knowledge. So thank you very much for all the attendees, and thanks again for the Hamsa team who made this academic session. And we are planning for more academic sessions like this on behalf of Hamsa. We would be expecting you all to attend to get benefited. Thank you very much. Thank you again. Thank you again.
Thank you, Dr. Karthikeyan.
Thank you, madam. Thank you. Right.
Thank you.